toric IOLs in irregular cornea. So whether to put on a toric IOL or not depends upon the stability of the astigmatism. If patient is using spectacles cylindrical power and his vision improves with cylindrical correction on the spectacles, then his vision will improve with the cylindrical correction in the toric IOL as well. But we need to tell him that his improvement will be as with the spectacles, not completely. So in irregular cornea, if any patient is using contact lens, particularly RGP, then the toric IOL contraindicated, because if it is comfortable, the toric IOL will never give that quality of vision what the RGP or scleral contact lenses will give. So I had to expand some of the keratoconus patient which was put the toric IOL. So the progressive and recurrent corneal pathology like PUK, Murens, mania corneosa, herpes simplex, recurrent immunological and infectious disease is a contraindication for these because the toricity will keep on changing. I'll take up the RK as the prototype for this post-RK toric IOL. And those who have not seen the RK surgery, so what we used to do is we used to give a radial cut leaving the central 3 millimeter. So because of the IOP, this radial cut you will cause the paracentral steepening. This will bulge out and that will pull this down. So there was a paracentral steepening because of the weakening and flattening of the center. And this goes on forever in the patient's life. This is what we call as a hyperopic shift. Initially, patient may be hemetropic, then he keeps on becoming hyperopic forever. And they usually diagonal fluctuation in these patients. These patients also have in the morning, they may be hyperopic because of the corneal edema, and by evening they may become myopic. So there is the diagonal variation as well in these patients. So I'll just, instead of going on to the theory, I'll just show my 2-3 cases, what happened to them. So this was a 51-year-old male with a prior history of RK, and his subjective refraction was -4 with -3.5 at 170 degree and vision was 612. And optical biometry, if you see that the average or the mean of the two was 37.49, and cylinder is very good agreement, 3.78 at 75, and the power which was given by Barrett formula was 13.5. And on the pentacam, actually keratometry was 39.4, and the cylindrical was more or less in agreement, and axis was also in agreement. So if you see that the target refraction, if we keep 0, then optical biometer was more accurate than the pentacam because the ocular biometer is flatter as compared to the pentacam. So we need to take a flattest reading, so which was very good in this case, and we always calculate on IOLCalc.SCRS.R. And then another point was whether to use the toric or no toric. So in this case, there is absolutely no confusion because there is very good agreement on the toricity as well as the axis of the patient. So another is what IOL power you use. So I always target refraction -1 in all these patients. So this comes to around 15 diopter with the toricity corrected by this. So this was very simple, absolutely no confusion. And the patient was myopic and the IOL power was on the myopic side, is perfectly all right. This is another patient which had 56-year-old patient. And in this, you can see that the astigmatism is 6.25 at 172. The total corneal power is 36.6. And the power which was given by the SRGT of Barrett was 21 diopter. But once we do the pentacam, the pentacam has the corneal total cornea value 32.5. Astigmatism 6.2, volume is the same, but axis is different from 172 to 149. And once we do the calculation, if we do the target 0, then the power which was coming minimum was 23.60, which was closer to the biometric values 21, 22. But the maximum was 27.64, which is because of the pentacam, which is 36.61, and there's a difference of the keratometric value of 4 diopter between the biometer and a pentacam. So we need to have the flattest K, and the pentacam is giving us a flattest K. And when we target -1, then the values were 29. So this is the important. So instead of now, I would have gone with this 21, 22 would have been grossly wrong. We went with the 29. And now the second point comes what axis should we correct the toric or not. So in this case, when there's too much of a disagreement, we did the auto ref reading, and you can see this is coming 8 diopter of central power at 164, 165 degree. And while the biometer axis is 172, 149 pentacam, so we went 165 with accent result. So in such an irregular astigmatism, the refractive astigmatism is extremely important. This is another case, 52 years, 32 incision, unaided vision counting finger. And if you see over here, what we are getting, the total IOL power was 10.5. This was, I didn't realize at that time. And the total corneal power was 41.64. And this is the type of astigmatism patient had. So we went to IOLcalc.com, average was 9.79, minimum was 7.7, maximum was 11.5. We went for the 12.5. And to our surprise, 1 week post-op, patient had 7 diopter with +5 diopter cylinder. 3 weeks, this was like this. AR was 13.5 with 1.5 diopter cylinder at 145 degree. And the acceptance of the patient was 9 diopter spherical with the 4.5 diopter at 140 degree, and vision was 6.9 part. So there was a total surprise. What next? We went for the IOL exchange. 1 month post-surgery, that's it, to go for IOL exchange. And I presume that 27 should be all right, and place the 27. And at the end of the surgery, the patient had, now we didn't put the toric IOL. It was 3-piece IOL which was placed. And with the -2 with the +5 cylinder at 145 degrees, 612 part. If you see, the spherical equivalent was still on the plus side, which I was not very happy. So the over scleral contact patient had this vision. So very simply, when you see the optical biometry, 1 diopter of the IOL power changes nearly 0.67 diopter of the refraction. So whenever you see the 0.5 step, it keeps on changing by 0.32, 0.32, 0.33. So if you presume that that is accurate, then IOL exchange calculation based on over refraction, if I go for that, so a spherical equivalent of +9 plus 4.5 is 11.25. And if we make 1 point multiplied by 1.5, it is 16.87. And IOL, which was put initially, was 12.5. We add 16.87 to this, makes it 29.37, which should have been more accurate than using 27. What I want to highlight that over refraction is very crucial whenever you are going for a IOL exchange than anything else. So refraction in irregular cornea, either post-op or pre-op, is the key whenever you are dealing with the irregular cornea. So there is another patient whose IOL power was coming in 2 and +2 and -6. So we planned for secondary IOL. Post-op refraction was +13, and secondary IOL was implanted with 26 diopter. So the important issue is that whenever you are not so sure, secondary IOL is always an option. And probably whenever the power is coming like this, probably you are taking the keratometry of the actitic area. So we need to have the flattest keratometric value. We need to calculate on IOLcalc.ASCS.R. Target refraction should be between -0.5 to -2. Usually I keep it around -1. Any keratometric value above 40 is suspicious. It may be paracentral, because most of the time, normal cornea is 43. Whenever you are giving an arc incision, it is going to go down. Any biometric value below 18, you have to cross check, because if the hyperopic, unless patient is already having a myopic refraction, then it's fine. If it's having a hyperopic refraction, then patient should definitely have more than 21. And in my experience, and whatever I had done the hypothetical analysis of the patient, if it was -6 corrected by RK, -5 corrected by RK. So I come to the conclusion that most of these patients need a power of 24 to 28. If it is coming less than that, be careful. Astigmatic correction by refraction and cylindrical power is equally important. Post-op refraction to IOL exchange is extremely important. IOL exchange and secondary IOL is always an option.